afternoon. My name is Elizabeth Gower, and today we're going to be talking about cardiovascular emergencies. I'm a paramedic with Johnson County EMS, been a paramedic since about 2016. So let's go ahead and get started. So like I said, we're going to be talking about cardiovascular emergencies. So our objective today is what exactly is a cardiovascular emergency? What are some kind of common cardiovascular emergencies that we see on a day-to-day basis? So what are some signs and symptoms you can expect to see with these patients? What kind of lifestyle, what kind of medications can cause these rhythms? Some basic medications that either the patients can take at home or were given on an ambulance. We're going to do a quick 3-lead and 12-lead overview. We're going to go into more in-depth information about the rhythms, the treatments, how EMS can impact the patient outcome, the hospital, why hospital designations matter, and then a quick summary, and that's about it. Alright, so to start off, so what is a cardiovascular emergency? A cardiovascular emergency is any emergency that is directly affected or caused by the heart or affects the heart, or anything really with the vascular system. They have a broad range that can either vary from a minor blood pressure abnormality, a chest pain, to a STEMI, or to eventually cardiac arrest. So now we're going to move on to some common types of cardiac emergencies that we see on a day-to-day basis, either in the pre-hospital or the hospital setting. So a common type of cardiac emergency is called angina. It can cause chest pain. It's due to the heart not receiving enough oxygen-rich blood. It's common, but like you said, the patient still sees it as an emergency because sometimes they have never felt this chest pain before. They don't know what angina is, and it's always important to be evaluated with chest pain, either by an EMS professional or by the hospital ultimately. So there's two types of angina. You have stable and unstable. Stable typically lasts for about 5 to 10 minutes. It's typically triggered by exercise, just overactivity. These patients typically know they have angina, know what causes it. Doesn't come really as a surprise to them. They have medication at home, either nitroglycerin or something else their doctor prescribed that helps them go away. Normally rest will take this away. Then you have unstable angina. So that's unstable angina. It's kind of like a surprise. It comes on just randomly. They don't have anything that triggers it. Medication normally doesn't make it better quickly. Normally lasts longer than 10 minutes. This is the type of angina that normally might have to have a heart catheterization or further evaluation at the hospital, further lab work to make sure everything's okay. And then we have some blood pressure abnormalities. So there's two types of blood pressure abnormalities. There's hypertension and hypotension. So hypertension is obviously when your blood pressure is abnormally high. Then there's hypotension when your blood pressure is abnormally low. So hypertension is common. It's obviously characterized by abnormally high blood pressure. It can be treated by a medication change, lifestyle change, diet change. But unfortunately, if it's left untreated, it can lead to a stroke or other complicated medical problems. Some people with high blood pressure, they never ever have symptoms. They can live with a blood pressure of 170 over 90, and that's just their normal. Other people, when their blood pressure starts to get high, they have blurred vision, headaches, chest pain, palpitations. It really can present in a lot of different ways. If this is the first time that your patients ever really have blood pressure problems, that they definitely need to be evaluated by a hospital to see what's going on in their body. So, like I was saying earlier, textbook normal is 120 over 80, but everybody varies. Some people can sit just a little bit higher than that and be just fine, and never have any problems and never need medication or anything like that. Then you have hypotension. So that's characterized by abnormally low blood pressure. It can be caused by different medications. Sometimes people take too much of their medications. Sometimes people are put on too many medications by different doctors and their blood pressure just drops. People who are dehydrated or just have a fluid imbalance somewhere, that can cause their blood pressure to be low. Have some perfusion issues. So symptoms can include, obviously, the severity of your blood pressure. So you can either have some syncope, especially when people stand up, their blood pressure drops, and they drop too. They have weakness, some dizziness. It can be caused by an overall systemic infection or sepsis. It can cause ultramellistatus if it's low enough. So technically, hypotension is under 90/60, but again, that's going to vary patient by patient. Like me personally, I can sit at 90/60 and be just fine, but somebody right down the block, if they get to 90/60, they could be having syncopal episodes, maybe altered, dizzy, all that jazz. So on to the big one. So this one is called a myocardial infarction, or a STEMI, or STEMIs group into that. So it is what typically people refer to as a heart attack. It's a very severe type of cardiac emergency that must receive treatment. So it occurs when the blood flow to certain parts of the heart is stopped and your heart becomes ischemic, which means it doesn't receive enough blood, oxygen-rich blood. So it will most likely show on a 12-lead or your lab work. So the blood is either stopped by your vessel constricting or a blockage in your vessel or your artery. So it does have a 30% mortality rate, with 50% of people dying at home or wherever they are before they ever reach the hospital. So with STEMIs, a million different things symptom-wise can present. They can appear pale, diaphoretic, they can have to be altered, they can just be having chest pain, some palpitations, their blood pressure can be low. So there's a million types of symptoms that you can expect with the STEMI, because everybody experiences these symptoms differently. So there's different types of STEMIs, and normally they're classified by 4 different categories on where the heart is actually infarcting. You have your lateral and your inferior, your anterior, or septal, or lateral, inferior, anterior, or septal. So not to get into too much, but on your 12 lead, you'll see the elevation in certain leads, and that typically can pinpoint you on where the actual ischemia is. So then we're going to move on to atrial fibrillation. So it is referred to as afib or an irregular heartbeat. It is common, a lot of people have it, but it is an emergency, especially if this is the first time someone's ever gone into it. So it occurs when the atria, or the top of your heart, begins to quiver, and it's not beating like it's supposed to, and it's off sync with your ventricles, or the bottom of your heart. And obviously it makes it difficult for your blood to pump throughout your body correctly. So it can be treated by medications, or a lot of times it can be treated by electrotherapy, a cardioversion at the hospital, or if it's severe enough in the pre-hospital setting, it can also be treated by cardioversion. So a lot of people present with heart palpitations, their blood pressure is abnormal, they have some general weakness, shortness of breath, and then ultimately it can cause blood clots if left untreated for a while. Patients are normally sent home with blood thinners due to the increase of risk of blood clots. So that is an example of AFib. It's just kind of everywhere. All your QRS complexes, which are the big ones right through there, they're going to be sporadic, random. They're not really going to have any pattern. There's also atrial flutter, which these right through here is going to look like just flutters. So then you have supraventricular tachycardia, or SVT. So that is characterized by a heart rate of over 150 beats per minute. So it causes the body's blood flow to be disrupted due to the heart being unable to pump properly because it's pumping so fast. So patients feel weak, some palpitations, some shortness of breath. They may have chest pain. So it can be caused by some medications. It can be caused by electrolyte imbalance, some dehydration, or drug use like cocaine, methamphetamine, stuff like that. Or it can be caused by prior cardiac abnormality, either genetic or something you had surgery for later on in life. Then we have symptomatic bradycardia. So technically, textbook is bradycardia is anything with a heart rate under 60. So again, kind of like with the blood pressure, some people can sit at 50 and be just fine. Some people, their medication causes them to sit at 48 to 50, and they're just fine too. And they handle it with no issues. But some people cannot be that low without it causing some altered status or other kind of symptoms. So your treatment's always going to be determined on the severity of symptoms and your cause. So it can be caused by dehydration, either a medication that's just not, you either took too much or it's just not right for you. It can also be caused by heart blocks or other cardiac abnormalities. It can cause altered mental status, weakness, hypotension, or a cardiac compromise. Treatments can vary from fluid boluses to medications to electrical therapy or pacing, depending on how symptomatic your patient is. And you have symptomatic tachycardia, and that is defined as a heart rate over 100. Again, this is always going to be determined on how bad your patient is and what their underlying cause for the tachycardia is. So it does, like I said, typically has a secondary cause. It can be caused by dehydration, sepsis, infection, fever, stuff like that. It's normally not cardiac related, meaning, like I said, it's caused by something else. It may cause hypotension, shortness of breath, heart palpitations, or patients may experience some anxiety. Typically, in my experience, you normally don't treat this with cardiac medications because it's normally not to that point yet. It can be treated with other methods like fluid, Tylenol, fever control, stuff like that. So then you have VTAC, or ventricular tachycardia, which is also another severe irregular heartbeat that can lead to sudden death. So that's going to be characterized by these wide complexes over 120 beats per minute. Is defined as abnormality with the heart's electrical activity. It can be caused by genetic abnormalities, cardiomyopathy, which is just your heart being more enlarged, electrolyte imbalances, or like a STEMI or something else going on. Typically, there's two types of ventricular tachycardia. There's polymorphic, which means there's no rhyme or rhythm to the rhythm. It's wide and it's just kind of everywhere. Or there's monomorphic, which would be kind of like this, where it all looks the same. It's bad one way or another. So like I said, yeah, there's two types. So then there's VFib. So that is a lethal rhythm. It cannot sustain life. At this point, your patient is considered to be in cardiac arrest. So rhythm is a result of the heart quivering. So kind of like AFib, you know how the top quivered? Well, with VFib, your whole heart's doing that. It's not pumping any blood because it's really not pumping correctly at all. So you will not, like I said, you will not have a pulse. Your patient's considered being cardiac arrest, and at that point, you should start your CPR and normal cardiac arrest protocol. So that's what VFib is. It's just, like I said, kind of everywhere. There's coarse VFib and fine VFib. So coarse VFib will probably more likely be like this, where it's pretty obvious. It's kind of everywhere. And then fine VFib, if you ever see it on the monitor, it's little squiggles. If that makes sense. It's sometimes kind of hard to notice, but it is there. Then you have PEA, or pulseless electrical activity. So this rhythm is characterized by a patient who is in cardiac arrest. They do not have a pulse, but if they're placed on a 3 lead or 12 lead, they will have some complexes that normally would have a pulse in any other patient. So this appears in approximately about 55% of cardiac arrest patients. Then you have systole, which is death. So patient is in cardiac arrest. They have no palpable pulse. They don't have the rhythm. It appears as a flat line on a 3 lead. So that is defined as the total cessation of any electrical activity or contraction of your heart. So when a patient's in a systole, your prognosis is pretty poor. So it's the initial rhythm in about 28% of cardiac arrest. So if ROSC is obtained, which is just obtaining a pulse back, only about 15 of those patients will actually survive to discharge. This is normally the final rhythm after an initial non-perfusing rhythm like VTAC or VFib without a pulse. And that's just kind of, I'm pretty sure most people have seen that, but that's what systole looks like. So now let's move on to some signs and symptoms that typically we are either called for or patients experience. So they experience some dyspnea or shortness of breath. They may have some chest pain, some palpitations, some generalized weakness. They may have some GI symptoms like nausea, vomiting, diarrhea. They may have back pain. They might have some hypertension or hypotension, diaphoresis, which is just sweaty. Just a general unwell feeling that couldn't really tell you what's going on. Some pale skin. They may pass out or have a single episode, and they may have some altered mental status. So these are common complaints that we receive, and it's always important to be cautious when evaluating and assessing your patient, because every patient is going to present differently with their symptoms. Always use your best judgment as a provider, and if something doesn't sit right with you and you think there's more to it, investigate it the best you can. So women and diabetics, they may present differently. Some diabetics never have chest pain, just something else isn't right. And women also may present differently. Women typically don't have the classic chest pain moving down their arm or anything like that when they're having a heart attack. They can have abdominal pain, back pain, just some GI complications. So always be cautious with these patients, with really any patient, when you're assessing them. So what can cause some of these emergencies? Unfortunately, some people are born with heart abnormalities and that they have to deal with their whole life, either valve issues with Parkinson White, or just surgeries that they had when they were children. Your genetics make you predisposition to high blood pressure or cardiac issues. Some of the medications you can take, sometimes, like I was saying earlier, a lot of the elderly population, they see one doctor for one thing, they see another doctor for another. They're put on multiple medications, and they just sometimes just don't have the education to know that they're not supposed to take these medications, and no one ever sat down with them and said, hey, we shouldn't take both. And that can either lead to an arrhythmia, some hypotension, or really anything. So dialysis and electrolyte balances, they kind of go hand in hand. A patient on dialysis, they have a lot of fluid taken off from them,